here I mean 15 to 17 are considered as minors, and we also need additional consent. For the tool, we have adapted the concept attributes as I presented in the conceptual framework, and we use the data collection toolkit to facilitate the data collection process. We therefore, before starting the main data collection, you have piloted the tool to see if the adaptation we did may not interfere with its validity and reliability, and we find the Cronbach alpha of to be good, 8%. Now, looking at the components of the tool, we're having many variables to make sure that all attributes are assessed. We first look at the viral load. We met with adolescents with HIV, and we're working with the nurse, the personnel in charge of antiretroviral therapy at the health center level. So we were looking at we were making chart review of viral load, and for the quantitative tool we're having, so we had the questions related to sexuality, and also the ART medication adherence. We looked at the HIV stigma, depression, hope, the self-esteem, resilience, HIV disclosure, the perceived social support, and HIV quality of life. We later found a Cronbach alpha of 80% after piloting the tool. So the tool was made of 6 parts: the general information, the social demographic information, the sexual reproductive health and biological characteristics, behavioral characteristics, psychological characteristics, and social characteristics, to make sure that all dimensions of successful living are worked on. As a result, we computed the latent profile analysis, and we looked for the BIC, which is close to 0, as the latent profile analysis requires, and we found it to have 2 groups of successful living among adolescents with HIV, and they are the ones I'm presenting on this slide. Among those 2 groups, you can find the graph in red and another graph in green. The graph in red indicate adolescents who do not successfully live with HIV, who struggle to live with HIV, and the graph in green is for adolescents who live successfully with HIV, considering different variables, considering the viral load, the number of sex partners in a lifetime, having sex and using condom. So these findings are complementing other findings that were presented before, because we also looked at this: the HIV antiretroviral therapy adherence, the HIV stigma, variable 5. Variable 6 was the depression, variable 7 was the state of hope, variable 8 was the self-esteem, variable 9 was resilience, variable 10 was the disclosure, HIV disclosure, variable 11 was the HIV quality of life, and the 12th variable was the perceived social support. And when you look at how they differ, each variable was different across those 2 groups, and you find some of the variables to be higher in adolescents who struggle to live with HIV, while others are low in adolescents who live successfully with HIV. So they are different, as you can see on the graph. We also looked at the social demographic characteristics and found the successful living to be decreasing with age, as you can see, suggesting that young adolescents may be more resilient or adaptable in coping with the challenges caused by HIV because they are still young. They are not, their level of thinking is not projecting well to the future. So you find to be stable compared to adolescents who have 18 to 19 years. And also when you look at the level of education, was opposite because those with higher level of education was having good quality of life and successful living with HIV. We also looked at the correlation among these variables, and we found that to be correlating because when you look at these p-values, which is less than 0.05, they are numerous, and our coefficient, our variables really was correlating. So by definition, we first came up with the definition of successful living, which is a positive living experience of adolescent with HIV, characterized by the ability to achieve the optimal biological, behavioral, psychological, and social well-being without considering only the biological dimension. And for the studies, the findings that we have got, the two phenotypes clusters we found, one was struggling to live with HIV at 53%, at 47%, around 46, while the successful living of adolescents with HIV was 54%. And when looking at these findings, we reflected on the level of adherence of this age group, as well as the viral load suppression, which is low, and we found to be a correlation because higher levels of successful living were mainly associated with the high educational levels, as we have seen on social demographic characteristics. Those living in families or in a stable home environment were also having the improved positive living compared to others. Also, the health insurance coverage also was playing a positive role. Receiving social support also was contributing, and as well acquiring HIV through vertical transmission rather than other means was part of the successful living. Here I mean those who have got HIV from their parents, not through other means of HIV transmission. We also found early adolescents to be causing the successful living among this age group. So as contribution and the strength of the study, we found that the phenotypes of successful living, it is a novel approach because for the previous studies we were looking at the deficit-based approach, but this strength-based approach we believe to be contributing mainly in the medical field for the HIV care management, as well as the education and the research. So we employed the pragmatism paradigm to look at different aspects, qualitative and quantitative, and be able to get insight from the study participant for our results to be comprehensive. Also, our participants were recruited from diverse background, where the random sampling was used at all health facilities, ensuring fairness in participant selection. And the psychometrically validated instrument was also other strength of the study. Now, as a conclusion, we found that the successful living is a holistic concept beyond viral load suppression, because you find that in some reports, the viral load suppression have been considered in some places as successful living, but this is the successful living of adolescents is really a huge component. In Rwanda, 54% were successful living with HIV, but there should be framework for tailored health strategies that focus on each phenotype and screen each adolescent with HIV whenever they visit the health facility and know how the package for medical interventions for adolescents with HIV should be followed. So the recommendation here was to have a tailored interventions considering two groups of adolescents with HIV, but without providing the generic intervention, because by providing the generic intervention, their level of adherence has been still very low, and the viral load suppression is still low. And considering the attributes of successful living, whenever each adolescent with HIV is assessed, is screened, and determine at which level he is successfully living with HIV and which attributes are affected, this may lead the next step to follow. He will be getting the antiretroviral therapy, but with other intervention to support him. And we also recommended future longitudinal studies to assess now how adolescents with HIV transition from early to late adolescent, as well as from late adolescent to young adulthood. We believe in future studies, this also may be explored in order to come up with a well-developed, personal-centered, cultural applicable, and contextually relevant intervention, which is specific to those two phenotypes of adolescents with HIV. So we really acknowledge different partners who made this study feasible. First, the participant who sent the consent and assent form, allowing us to be interviewing them, without forgetting the RBC, because RBC has been like an umbrella which was supporting in everything, having access to participants, and also providing some additional resources. We also thank the funder, the ERIMA project, which has supported the entire process, the team that participated in data collection, as well as the transportation for participants for easy access. We thank you very much. Thank you. Can you hear me?
Yes, we can hear you. Thank you so much for the wonderful presentation. I've learned a lot about what is successful living and what are some of the factors.
Hello, can you hear me?
Can you hear us?
Yes, I can hear you.
Okay,
Thank
thank you
you.
so much for the presentation. Saying that I've definitely learned a lot about successful living, what it means, and what are some of the correlates, especially regarding adolescents. So it's time for panel discussion. I'll ask the presenters to please come up, but I'll also invite a few other additional participants who will join the panel, because we need to hear from other voices, especially the community voices. So I'll invite Umutesi Fiona, if you're still around, to please come. Fiona is a public health professional and a registered nurse. She has extensive experience managing community-based programs, and she will bring us the wonderful insights. I'll also ask Dr. Mundu, who is a public health leader and a researcher in Kigali, and she's currently serving at WHO Rwanda as a program officer for HIV, STIs, TB, and hepatitis, to join the panel. But I'll also ask Sam Harajirimana, who is our operations manager at Rwanda NCD Alliance, and he'll also bring wonderful discussions, especially around integration of NCD care. Please have your seats. So Gaita, Catherine, Christia, Dewo, And Diodone, please continue joining online. After the panel discussion and question and answer session, we'll have a final presentation as well. Let's ask Joel Gasana, who will come in to take over the moderation of the panel discussion and the rest of the session. Thank you.
Thank you. First, let us give a round of applause to the morning MC and moderator. I think she did it very well and she left a big thing. Thank you. I'm Gasana Joel. I'm glad today to be the moderator of this panel session, which is going to be engaging. It's a very huge one as you are seeing it, and we had so many information from different presentations. Yeah. I'm not going to go back in the introduction. We had them in the morning. For the interest of time, we are going straight to the point. My first question goes to Gaetan, which is currently the acting director of HIV epidemiology surveillance. During the presentation, we have seen that there is currently a double burden of HIV and NCDs among people living with HIV. What do you think are current main implications of this finding for the Rwandan health system?
HIV, we are progressing well, and we have high ART coverage and viral suppression. But with this growing NCD burden, I think it can undermine our achievement. So we need to address this by integrating NCD in HIV services to screen and manage NCDs in our routine HIV care, and so that a patient can live a good life and also with minimal health-related costs. Yeah, I think the implication is to accelerate the integration of HIV and NCD services. Thank you.
Thanks so much, Gaetan. From the perspective of the community, I'm going to ask Fiona, who is the representative of RP, please. What do you think are the role of communities and network of people living with HIV play in preventing and managing HIV? I mean NCDs in people living with HIV.
Thank you. As Rwanda network of people living with HIV, we play a vital role to prevent and manage NCD through peer support groups where we create safe space and people get time to learn and share experiences through lifestyles, and they get to know different things about their peers, and through that management and integration, we, as LLP Police, we help them to link them to the health facility for those who have some problems. Thank you so much.
Thank you, Fiona. My next question goes to Sam, who works for the Rwanda National NCD Alliance. From the perspective of development partners and the Alliance, why do you think the integration for NCDs in the HIV service is necessary, and what do you think are the challenges?
Okay, thank you. For the perspective of NCD advocates, first of all, NCD patient and the HIV patient, they are sharing the common condition. They live their entire life on medication. And some of the diagnostic text the NCD patient are receiving, some of, for example, on hypertension, it's blood pressure. And those blood pressure, they are being also taken in HIV clinic. So it's better for integration because some of the care are interlinked. And the second is efficiency and the cost effectiveness. If you correct two blood pressure on only 1 week, for example, there's sometime a patient having like an appointment on a Monday in the HIV clinic and having another appointment on a Wednesday in the NCD clinic. So, and those tests, they are being independently taken by each service. It's kind of waste of resources for healthcare provider and the entire health system when those tests are being taken in duplicates. And also for the patient, we need to alleviate the burden for those recurring, coming forth and back to the health facility. And such integration approach will also help to retain the patient in the service. Also, they having both HIV and the NCD patient, they experience stigma in the community and the families because of out-pocket expenditures. So it's better to have a holistic approach to help those patients. And the challenge, there is a resistance for donor and the development partners, particularly those in HIV, because in HIV it's well advanced and full funded. For NCD, the funding is still low. So there is some people who think mixing their service and their interest, it's a kind of just, is it contradicting their missions? So it's better to have a harmonized approach, and we need to improve our mindset and the philosophy because we are helping the patient. It's not sticking on our view, on our mission, vision. We need to have a patient-centered approach to help a patient in a holistic manner. The main challenge is that funding. Another challenge is infrastructure and the human resource. There is a system where we normally train the healthcare providers in one service. Then when the patient came to the health facility, they say, this is the HIV patient, go, your nurse is there, your doctor is there. For the HIV, the same story. NCD, the same story. It's better to have healthcare provider trained on both conditions so that once the patient reaches the health facility, get treated at one site, at one point, and on the same cost. And then once we use that approach, the care that are subsidized for HIV will be subsidized to NCD patient too. Thank you.
Still on integration, I know WHO is working, having different initiatives. Can you please enlighten us on integration of those services?
Thank you very much, Dr. Joel, and thank you for giving me this opportunity to talk about integration. For me, when I talk about integration of NCD and HIV, I think the way we are calling even them, one is non-communicable disease, other is communicable disease, but they are all chronic diseases. So I wish we should have this discussion 2 decades back of integration. Unfortunately, we are here to discuss it. So it is late, but we need to go for integration. Why HIV services, we saw data here how achievement when it's come to 395, we are even, we are better, but we forgot back there. I'm part of people who forgot to think about these people are living longer. So why living longer means NCDs are there. These people are taking medication with side effects. So now, by now, we are seeing where the life expectancy increased with people in HIV, but you may lose them because of NCDs. So we need to integrate. So WHO, I think our slogan is integration. But integration, how can we integrate? We are not recommending the mode of integration as WHO, but we need to adapt it for our context. Especially when we talk about integration, we say we need to go to decentralize our services into primary health care. For Rwanda, we are there. We have HIV services at primary health care. We have non-communicable disease at primary health care. But they are parallel. But people are not parallel. How are we approaching an holistic way when we are treating someone with NCD, with HIV? I have my appointment for HIV today. I have my appointment for NCD after tomorrow. I have my 6 months medication for HIV, but for NCD I have to come to the clinic every month. So we need to think about all this when it comes to integration. And again, the model of integration, yes, we have WHO guidance on model, but as the country, we need to sit and see which model fit for us. Again, when we sit here and see which model fit for us, let us think about the community. Which model fits for the beneficiaries? That's the most important. And my colleague here talk about the financial crisis, but still this can be one of the way to go out of this. I was discussing with my colleague and say, you people from HIV, you are now ready to integrate because you no longer have funds. So we don't have people from HIV, people from NCD. We are serving one person, and this person should receive a comprehensive package and receive it at the same. So what is the, how can we integrate in our setting? Integration, we have different model. When we say integration, someone was saying we are integrating NCD, mental health, HIV. Will all these services be offered by one person? So that's why we need to see which model fit for our context and for our beneficiaries. I think that's what, we have different models at WHO, but we need to sit as the country and see which one fit for our population we are serving. Thank you.
Thank you, Dr. Mundu, for the clarification. I think we are writing down homeworks, and the first one I got, it's how do we adapt, how do we fit our model to our local context. Our next question is going to talk about the key population that sometimes services have been seen to be reluctant to service delivery to key population have been seen to be reluctant to them, though other UN AIDS targets have been achieved. My question is to Catherine. What do you think can be done to help, especially female sex workers, as you have shown in your presentation, to get tested to know their HIV status and even go for treatment.
Thank you. Through my presentation, we see that the female sex worker, the proportion of female sex workers who were tested for HIV is still low. Then we should increase the education on HIV testing and increase outreach community, because some of them didn't visit his facilities, so that the implementing partners should help us, or should help government of Rwanda to sensitize the female sex workers to get testing for HIV. For those who are already aware of HIV status, we have to stimulate them to use